Hi, this is George Hanzel from Beaumont Hospital, and I'm with Dr. Cliff Kavinsky from Rush, and we're here to discuss left atrial appendage closure. SCAI and ACC and HRS are issuing a joint consensus document, and Dr. Kavinsky has been instrumental and a prime writer of this document, and we're going to discuss that this afternoon. Cliff, can you provide some background on the consensus paper that's addressing operator and facility standards for left atrial appendage closure?
Well, the process leading to the FDA approval of the left atrial appendage occlusion device, the Watchman device, has spanned almost 18 years. It has encompassed 2 randomized clinical trials, several registries, and 3 FDA panel hearings before it was approved. Following its approval this past spring, the stakeholder societies, namely the ACC, HRS, and the SCAI, decided it was necessary to put joint statements together in order to guide the safe and efficacious rollout of this considered paradigm-changing technology. And just a few weeks ago, the first multi-society document on left atrial appendage occlusion was actually published in JACC and SCAI. And it was a general overview of the field of left atrial appendage occlusion, and it was felt that as a corollary to that document that a follow-up manuscript would be put together which would guide institutional and operator requirements to engage in left atrial appendage occlusion so that the rollout of this technology would be controlled, safe, and efficacious. And that was the background leading to this document, which has been prepared and ready for publication basically on the 10th today.
Great. Fantastic. We're looking forward to seeing it in its entirety. Can you summarize some of the recommendations for institutions?
Well, we want to make sure 2 things. First, that the operators have the right background, and also that we understand that a left atrial appendage occlusion program is not dependent on a single individual, but crosses multiple specialties and is really an institutional commitment to this technology. As such, it was felt that it is just as important to make institutional requirements as it was operator requirements. And so from the standpoint of institutional requirements, there are a series of mandates, the most important being that there should be a structural heart disease program or an active electrophysiology program such that the institution will have engaged in at least 50 structural heart disease or left-sided EP procedures, of which 25 of these procedures involve transseptal puncture through an intact septum. So this tells us that there is a program at this institution which is engaged in structural heart disease and advanced EP procedures.
Now, for individual operators, obviously we're looking at interventional cardiologists, electrophysiologists, and imaging, which is critical as well. What are the recommended guidance for those physicians?
So we have to understand that operators engaged in left atrial appendage occlusion will come from a variety of different backgrounds. They can be structural proceduralists, they can be electrophysiologists, they could be pediatric cardiologists, they can be even surgeons. So we have to create a list of requirements that would allow any of these different types of specialties to engage in this technology, and we don't want to be exclusionary of any type of physician. In fact, we refer to left atrial appendage occlusion physicians as procedural specialists. And in terms of volume and type requirements, we have mandated that anyone who wishes to engage in this type of procedure will have done at least 50 structural heart disease procedures lifetime, and these procedures could include left-sided EP ablations or structural heart disease procedures. Now, the different types of structural heart disease procedures which would be considered acceptable are listed in the document, and they consist of certain things like percutaneous mitral valvuloplasty, or anterograde balloon aortic valvuloplasty, or placement of a tandem heart device, which requires a transeptal puncture. The additional requirement is also that the operator will have done at least 25 transeptal punctures through an intact septum in order to be eligible to do this procedure. So the requirement reads 50 structural procedures or left-sided EP procedures, and at least 25 of these procedures have to involve a transeptal puncture through an intact septum.
Okay. And I assume that's 25 transeptal punctures per lifetime. There's no yearly requirements.
Lifetime. Okay. So there are requirements to initiate a program, and there are also ongoing requirements. So the ongoing requirements are that over a 2-year period, that the physician will have done at least 25 procedures that involve transeptal puncture through an intact septum, at least 12 of which will be left atrial occlusion procedures. So, in other words, you got to continue to do procedures, structural heart disease or left-sided EP procedures, and you got to do a very minimum of 6 left atrial occlusion procedures per year to maintain competency. Now, we have purposely made these requirements as lenient as possible without compromising patient safety in the hope that we will not be exclusionary of any bona fide programs who wish to get involved in this technology.
Great. So those are the operator numbers. Are there any institutional requirements in terms of number of left atrial appendage closures done per year?
No, the institutional requirements mirror the operator requirements on an ongoing basis.
Great. Are there any other salient points in the manuscript that you'd like to elaborate on?
Well, I mean, in terms of institutional requirements, there are requirements, I don't want to go into these in detail, but there are requirements for physical facilities. I think that the writing committee felt strongly that there should be an on-site active cardiovascular surgery program in order to support this kind of technology, so that in the event of a complication that would require surgical intervention, that the surgeons would be there on site. So this is a very important aspect, and we felt that if an institution does not have an active on-site cardiovascular surgery program, they should not be engaged in this kind of technology. Secondly, we felt that operators should not only meet the requirements which I have stated, but they should be educated and knowledgeable about recognizing and treating the complications of this procedure. Being able to do a quick and efficient pericardiocentesis, being acquainted with all the equipment, devices for retrieval of embolized devices is something that we feel that operators should be acquainted with. So being able to deal with complications, having an on-site cardiovascular surgery program, having a program to monitor, an institutional program to monitor patient outcomes, operator outcomes in terms of efficacy and safety, and of course, as you know, being involved in a registry that will include all patients.
Good. Great. That's a great segue. I'd like to move on and discuss the CMS response. As I think most people know, CMS came out with a proposed national coverage determination about a month ago, and the public comment period is ongoing, and SCAI is going to be submitted.
So, George, I don't know if you've had an opportunity to read that proposal from CMS, but we have found it very interesting. So the FDA approval for the Watchman device says that it is approved for patients with atrial fibrillation who are at risk for stroke, who are eligible to take anticoagulation and for whom a rationale exists to seek a non-pharmacologic therapy. The CMS proposal for the NCD is quite different from the FDA approval in that it seems to seek application of this technology for patients who have contraindications to anticoagulation. In fact, one of the key points in their proposal is that a patient have contraindications to anticoagulation to be eligible for this technology. And as you and I both know, in all the randomized controlled trials, all the patients included were to be eligible to take warfarin in order to be studied. So the patient populations which are included in the NCD proposal have never been studied in any of the randomized controlled trials. So the three societies, HRS, ACC, and SCAI, were quite surprised at the proposal as it existed. And we felt, all three societies felt, that a thoughtful response letter, comment letter was called for, and we have put a letter together that I think becomes more granular on which kinds of patients should be done and how they should be followed. We found it, again, we found it quite interesting how kind of general the NCD proposal was, and we spent a lot of time trying to refine their letter so it could be applied to real-world medicine.
Okay, gotcha. All right, with that, I know with, there's a couple questions that regarding the, contraindication to anticoagulation has bled, the LAA registry. Is there anything in particular there that you want to go over here, or just keep it broad, or?
Yeah, I mean, everyone, the NCDR is going to have a registry. There's already been several meetings about it. We expect it to be up and running. Any institution that's going to be active in this area will be participating in this registry. It is very similar to the TVT registry for TAVR. So I think this is a mandate from the CMS, and I think I agree with this. We need to follow these patients.